Hello everybody. Can we خلاص is everybody establishing their place on the exercise tables? Actually, I would like to welcome you all to our quality workshop. I want to say a very small note. All hematologists were not interested in quality at all. In particular, every hematologist. And also one of them is on the stand here. She was one of the people who said, I don't care about quality. But she became interested. And this is a success. This is the advantage of our repeated quality workshops. She became interested. And we are very glad to host her today to give us her presentation together with the rest of the quality team.
Thank you.
طبعا دكتورة نيفين قاسم does not need any introduction.
Thank you very much. بس لو تعرفوا خد مني مجهود قد ايه اني اقنع الدكتوره امينه انها توقفني اتكلم على الكواجيليشن على الكواليتي. قالت لي انت بتتكلمي في الكواجيليشن بس مالكيش في الكواليتي، فخدت مني وقت عشان اقنعها وقعدت يعني تكلمني يعني ميرسي انك وافقتي في الاخر. First, I'm really honored to be chaired by these eminent professors. دكتورة لاميا والدكتورة نرمين والدكتورة بالذات لازم أقول الدكتورة منى لأنها she's my mentor in quality. I'm really honored إن أنتم موجودين، وطبعا الدكتورة أمينة والدكتورة حنان. ما تتفائلوش قوي ان انا هتكلم في الكواليتي. انا عارفه ان طب اسكندريه يعني بايونيرز في الكواليتي ومن الناس اللي ابتدت بدري قوي، لكن انا I'll stress on points. لاحظت ان ناس كتير من الهيماتولوجيست they are not aware of. فمن غير طبعا المقدمه المشهوره ان quality is something very important and it's very essential ان انا اطلع نتيجه في وقت مظبوط وانها تبقى مظبوطه تساعد على diagnosis and so on. عموما الكواليتي كنترول فيها 5 components: specimen identification, integrity, standardization of the instrument, internal and external quality assessment. I won't speak about all that, but I'll concentrate on 3 topics: calibration of automated instruments, the monitoring of accuracy and precision, and how to verify the reliability of the test results. Calibration. Most modern analyzers are arbitrary comparators, and this makes them very, very different from chemistry instrument. In chemistry, for example, creatinine you calibrate every day maybe, or every other day, and so on. In hematology analyzers, we calibrate every 6 months, and in Egypt, every year. We don't need calibration that frequent, but there are some circumstances that necessitate that I do calibration. And before I speak about calibration and monitoring, it's very important to know how my machine works, because this helps a lot. If I know an idea about automation, I'll really, whenever there is a flag or there is a note, I'll know immediately where the error is. Okay. A calibrator should be directly traceable to an international primary standard with exactly defined physical or chemical measurements. When to do calibration? The calibration is performed at the time of installation and when it is shipped and launched in the lab. I discovered that a lot of people don't know that the calibrators only calibrate hemoglobin, total white cell count, total platelet count, MCV. They don't calibrate white cell differential. And this is really important. To calibrate the white cell differential, it needs a very hectic procedure, and it can never be done except by the company representative. That's very important. Some important points about calibration, that these are conditions why we should do calibration before the 1 year or 6 months. Of course, following major preventive instrument maintenance, if a quality control material with an unexplainable trend or outside of acceptable limits, or upon advice of the technical support. But you need to know things very important in calibrates. Shelf life is 45 days, but whenever it is opened, it's only 1 hour. So if you have multiple labs, don't be fooled that he'll calibrate, he uses the same calibrator in this lab, and then he'll go and calibrate with the same calibrator. He must open a new calibrator, because really the shelf life is 1 hour. So you should take care of this. Precision evaluation is incorporated into the calibration process and must be completed with successful result before performing calibration. This is, of course, by sense. I have to be sure of the precision before I do calibration. After calibration, you should be sure that the engineer is doing linearity check after every calibration, because it differs. The last point is that if we have some problems in shipment and we really need to calibrate the machine, how can we manage? We can calibrate manually very well, but because Dr. Amina didn't give me enough time, so I won't say how are we going to calibrate manually, but it can be made. Following completion of calibration, we have to evaluate the quality control. How do we evaluate it? Either by normal patient sample or by commercial product, and it should be within the range of the in the machine. Okay, we finish with calibration. We have to monitor accuracy and precision. How we do that? There are several methods of quality control which complement each other. Relation between indices, of course, use of quality control material, duplicate test on patient sample, and statistical control with moving average mean. I won't talk much about quality control material because it's exactly the same as the rules in chemistry, and I'm sure you are all aware of. But I will stress on certain difference between us and the chemistry. That's, of course, is the charts. The MCV and the RDW parameter may show trend through the product shelf life. That is inherent error due to swelling of the cells that make them bigger. So don't panic when I run a quality control at the end and I find that the MCV showing 10 above. It's very normal. Don't panic. Don't say it is out of range. This is expected because the cells swell in the quality control material. Again, it is a common misconception that the quality control result must be located or around the assay mean. This is not a prerequisite, as the assay mean is a reference only and should not be interpreted as a true value within target range is the most important. And this is different than the chemistry quality control. Okay, what to do when we change lots of quality control? Quality control, I think this, you get around 15 or 21 control, and that's the lot number. So when I get a new lot number, what should I do? Before your current cell control lot expire, perform the following on your new lot. Confirm that recovered values are within the table of expected result. If not, you have to establish your own lab mean from the very beginning. Okay, what can we do, what should we do when we change reagents? The reagents are finished and I have to remove the tanks and get another one. You have to know that the tubes inside the machine still contain reagent for 50 samples. Either you discard, and this of course is a loss of reagent. Better is to watch the average mean, which I will speak about in a second. If it is within the range, there is no trouble. So this is a point you should take care of. Okay, the most important thing in quality control of hematology, and this is a very nice tool, it's the relation between blood cell indices. We all know that there is a perfect linear relation between the MECV and MECH. Simply, when the cells get smaller, they carry hemoglobin less by weight. So Bergen in 1985 calculated a formula that shows that the MECV equals 2.5 MECH plus 16. And at the same time, the MECHC can never go down when the MECH is normal, because MECHC, when it decreases that much, that means it's a very severe hypochromia and a chronic form of hypochromia. So whenever I see the MECHC is low and the MECH is normal, there is something wrong in my machine. So what causes discrepancy between the red cell indices? Not any discrepancy means there is something wrong with the machine or the reagent, because there are clinical conditions that can cause this discrepancy. Like what? Increase in the white cell count above 30,000 will cause turbidity, will affect the hemoglobin concentration, and we use the hemoglobin in calculation of the MECH and MECHC. So the indices will be all mixed up together. Presence of cold agglutinin. Of course, we also, when there is cold agglutinin, all the parameters are mixed up. In hyperosmolarity, and this is very important, when someone is diabetic and he has hyperglycemia for a long time, the cells are in a hypertonic solution, and when we aspirate and put in the machine, because of the isotone, it swells. So it will give high MECV and discrepancy between MECV and MECH. The other cause, an increase in reticulocytic count. The retics are larger in size and less in hemoglobin content. Of course, dimorphic picture. In spherocytosis, this is when I get the MECHC above the normal. And in hyperlipidemia, over 1,000, and this also causes turbidity. The tool that I use, and very few labs I notice use this it's not expensive, it is very easy to do, is duplicate test on the patient sample. The mean to check, it's a mean to check the precision of the routine work. Test 10 consecutive specimens in duplicate, calculate the difference between the pairs of the result, and derive the standard deviation. It should be not differ by more than 2 standard deviation, and this is the formula for the duplicate test. I have to run. Check test is similar, but it's not duplicate. It's one test. I do it in the morning, and then I repeat it in the afternoon, and I see the difference. Then I come to the very important item in quality control, and it's a blessing we do have that on hematology machines, because it measures or it monitors the accuracy, not the precision. So it's really very beneficial. The XB, it's the overall daily means of blood count parameter, will remain constant provided that the proportion of different categories of patient in a hospital remains more or less the same. If I have in a lab بيجيلي diseases مختلفة، لو قسنا الانديسز هنلاقي ان المين ما بيتحركش كتير and this is really very useful. لكن مثلا لو رحت معمل اطفال بيجيله ثلاسيميا كتير قوي وبعدين جه ناس تانية، هلاقي في discrepancy جامد ما بين الام سي في والام سي اتش سي، فمش هينفع ده. لكن في معمل بالذات بيجيله 1000 عينة في اليوم. This is really beautiful لأنه it monitors itself every 4 hours. XB is a method of quality control where a weighted moving average of patient sample results are compared to a target values. XB is an acronym where X stands for mean and B stands for bull, which is the last name of a doctor who developed this method of quality control. These are the indices which are monitored, and at least we can use 400 patients, but better to use 1,000 patients. The mean is done, the standard deviation is done, and every 20 samples he measures the mean of a 20 sample and compare it. So I have a continuous monitoring of the accuracy of my machine. And I'm running because I'm out of time. I'm speaking very fast. The batch is considered to be in control if the mean of a batch is within plus or minus 3% of the target value, although Bull stated a mean, but of course you have to do your own mean is much better. Okay, that is the XB. The XB are for the indices. What about the XM? We are knowing now there is an XM analysis. It's available in some instrument as the DXH 800 and 900. It's quality control method that uses an exponentially weighted moving average of CBC differential and normoblast and reticulocytic parameter and compares them with a known target values to monitor instrument performance. It's very new and it's very useful for these parameters. Okay, how do, the last point, how to verify the reliability of the test result. There are a lot of items we use together like delta check, correlation assessment, medical review, and assay turnaround time. The correlation assessment and the medical review is very important because we always look at the diagnosis, we always look at the other laboratory tests, if not compatible. For example, if I get reticulocytic count very high and then I find the LDH is normal, there is something wrong because it has to move together, I mean. So it's very important, and the important is the delta check. The delta check is comparison between consecutive tests on a patient within 1 or 2 weeks. Account should be taken of the diurnal variation and the expected CV of the instrument. Actually, I find something very nice. They used a lot of statistics and the CLIA and so on, and they did a rough guide to acceptable limits of difference, increase or decrease from previous result in 1 or 2 weeks. Hemoglobin up to 2 gram, MCV up to 6 femtoliter, MCH up to 5, platelet 50% different from the previous result, and white cells, it's difficult because of course a infection or antibiotic intake will change white cell count. Provided that there is no clinical explanation, a difference outside this limit should alert the user to technical error, faulty specimen, clots, inadequate mixing, or storage deterioration. This discrepancy can be checked by all these, and one of the beautiful tools that we have is the blood film examination, because by the blood film examination you can assess the white cell count correctly, you can assess platelets, degree of hypochromia, red cell morphology. It's really a wonderful tool. And morphological judging degree of hypochromia and differential counts. take-home message: 3 very important aspects of quality control in hematology are calibration of automated instrument done every 6 months by the manufacturer representative. Wide BC's differential is not included, and it is monitored by the XB chart, and calibration can be done manually. Monitoring of accuracy and precision of instrument done by RBC's indices, Levi-Jennings chart, and use of patient sample. Verifying the reliability can be done by correlation study, blood film examination, and medical assessment. And thank you very much for.
Thank you so much. Very interesting. But I have to correct one piece of information. I did not limit your time. I am limited by the organizers' instructions to give the speakers so much time. But I really enjoyed your presentation. Excellent tips in the hematology work. And if anybody would like to ask a question, we'll open the discussion for Dr. Nevine only.
شكرا دكتور نيفين على المحاضره الرائعه سمبليفايد. بس حضرتك بتقولي لازم نعمل لينياريتي بعد كل كاليبريشن. لينياريتي بعد كل كاليبريشن بنعمله للجهاز لكل البارامترز. فهل لو عملت كاليبريشن وبعدين فور سام ريزون وهي لو عملتي اضطريت تعملي كاليبريشن بعد فتره قصيره، لازم مانداتوري انت تعملي لينياريتي مره ثانيه، ولا جريمه الواحد يسكيب اللينياريتي بعد كل
You never need انك تعمل calibration في وقت قصير يعني. والمانيفاكتشر does the linearity study, but you have to be sure that he did it. It's a must to be done.
دكتورة نيفين، عندي سؤال. حضرتك you mentioned ان احنا ممكن نشوف الفاريشن اللي هي بسبب different conditions كده by two measurement, two consecutive measurement or duplication of a sample، وبنعمل 10 samples حضرتك ذكرتيها. بس if the condition is the same هنلاقي فرق؟ هو ده السؤال.
Any condition is the same. لا، ما هو اذا انا عملت الدوبليكيت او عملت التشيك تيست، انا عملت واحده والثانيه بعديها، if it's within the two standard deviation, okay, my machine is okay. If it is not, it's a tool that there is something wrong. And this is the importance of knowing how the machine works, because you can really know where does it need flushing and cleaning. Does it need, there is a clock you need to pass it, but it will show you there is something wrong.
دكتورة نفيد، معلش هستأذنك. دلوقتي حضرتك قلتي حكاية الكاليبريشن كل 6 شهور. طب لو أنا حصل ريبير في الجهاز، فور اكزامبل تيوب اتغيرت، فاكيوم اتغير، حاجة زي دي، يو ماست دو كاليبريشن اور هتكتفي بالثري بارامتر بتاعة الكنترول؟
مش عارفة الكلام. مش
لو حصل ريبير في الجهاز، عطلة، أي عطلة، غيرت تيوب، غيرت فاكيوم، أي حاجة من دي.
أوكي، عطل في الجهاز لو احتاج كاليبريشن، لا لازم هعمل الحاجات دي.
يعني لو احتاج، ولا اي ماست اعمل كاليبريشن لان هنا في جزء من جهاز اتغير؟
لازم هتعمل كاليبريشن. فلما تعمل الكاليبريشن ده you have to check بعد الكاليبريشن هو هيعمل اللينياريتي، ولازم تمشي الكواليتي كنترول وتشوفوا اخباره ايه.
يعني
وبيشنت سامبل
ما دخلش الكنترولز، ولو لقيتها 3 ليفل ماشيين كويس ما اعملش كاليبريشن، لازم الاول اعمل كاليبريشن. ابدا بمين؟
ما انت هتعمل الكاليبريشن عشان عارف ان في حاجه بايظه. ما هتعرف ازاي ان حاجه بايظه؟
لا، يعني انا دلوقتي خلاص في خرطوم اتقطع فاتغير، في فاكيوم حصل، فيه وقف.
هتمشي ما مش هتعمل كاليبريشن في عطل، همشي الكواليتي، لو لقيت الكواليتي كويسه خلاص. لكن لو اضطريت ان انا اعمل كاليبريشن، غيرت حاجه كبيره قوي 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 ومشيت كواليتي كنترول ولقيت الكواليتي كنترول وحش، لازم اعمل كاليبريشن.
اوكي.
لازم.
ليا كومنت دكتوره نيفين. اولا بشكر دكتوره نيفين على البرزنتيشن اميزنج يعني. هو بس بالنسبه لسؤال دكتور محمد، هو احنا لو غيرنا ميجور بارت بيأثر على الميجرابل، يعني يبقى انا محتاجه فعلا اعمل كاليبريشن. لكن احنا حتى في الكيمياء لو غيرنا لمبه ما بنعملش كاليبريشن، يعني وات ايفر بقى ايه الميجور بروبلم اللي حصل لا ما بنعملش. لو مش
طب انا يعني معلش اعذروني، انا هديكم الخلاصه في الحته دي. التيتس كاتب امتى اعيد الكاليبريشن، يعني وين شود اي دو لو الميجر بارت اللي غيرتها غيرت حاجه في القرايه it will be reflected على الكواليتي كنترول، وبالتالي الكواليتي كنترول هيحصل له يا شيفت upwards او downwards، يا اما هيحصل فلكتويشن برضو مع الشيفت upwards and downwards. هتعمل الكيوسم لو ماشي معاك هتكمل معاك. يعني تيت دلوقتي ما بيقولش حتى في الكيمياء اللي سهله الكاليبريشن مش بالسوفيستيكيشن بتاع الهيماتولوجي، بيقول لك do not repeat الكاليبريشن this is not a good practice. الجود براكتس انك تضمن ان الكاليبريشن بايظه بانك تقرا الكاليبريتور اللي انت كنت عامل عليه كاليبريشن كيرف القديم قبل ما تغير اللمبه او قبل ما تغير الماجرينج سيل او وات ايفر بارت غيرتها. والانسرتينتي بيطلب منك 6 اشهر عشان تكون مرت عليك حاجات كتير، من ضمنها تغيير لمبه، تغيير رياجنت، تغيير كاليبريتور، تغيير لوت نمبر اوف وات ايفر رياجنت كاليبريتور اور كنترول. وهي دي الانسرتينتي بتاعتك. انا عايزه اشوف الفاريابيليتي بتاعتك اخرتها فين. فدو نوت راش انتو ذا ايتم اوف كاليبريشن الا لما الكنترول يزعلك، يعني من الاخر.
بالنسبه لللينياريتي الجايد لاينز بتقول ان هي مانديتد كل 6 شهور، فاحنا كاب والايزو مش كل 6 شهور، لكن اللينياريتي ماست بي كل 6 شهور سواء كاب او جهار.
هستغل فرصه ان الدكتوره حنان موجوده معانا عشان هي بتحاول انها تبقى كاب اكريديتد لاب ان شاء الله وتنجح. هو في اللينياريتي تشيك سيتس، فهي دي غاليه، فاحنا مش بنستخدم اللينياريتي سيتس، احنا بنعمل سيريال دايليوشن لحاجات او كده. فحضرتك بتعملي ايه في ريجاردنج الكاب ريكويرمنت للاستابليشمنت اوف لينياريتي بعد كل كاليبريشن؟ عندك لينياريتي سيتس؟
لا احنا فعلا اشتريناها مره، لان هي بتبقى ليها انا ممكن استعمل اي كاليبريتور هاي، يعني هو اهم حاجه. نعم لا بتجمعي برضو اي كاليبريتور، او ما عنديش كاليبريتور بختار عينات هاي، وهي دي عشان اكفر الميجرابل ريدنج بتاعتي. يعني لو انا محتاج، المهم ان انا ما اطلعش ريبورتنج لاي نتيجه اعلى من الليفل ده عشان ما تبقاش فيريفايد.
برضو هقول معلومه صغيره، يعني ايه measurable range او measuring range؟ it is the range ما بين outer calibrator لاعلى calibrator. بعد كده بعمل حاجه اسمها extrapolation and we should not do this. فالlinearity is الميجربل رينج اللي هو الرينج ما بين اعلى calibrator واوطى calibrator. فعشان كده لو انا عندي variability lot to lot variability جامده في الكاليبريتور، او جات لي البامفلت انسرت بتاعت الكاليبريتور بفاليوز مختلفه، انا لازم اعيد الكاليبريشن عشان الحته دي، لان الميجرنج رينج هيتغير. لو كان بيقرا لحد، في شركات بتحسن الميجرنج رينج بانها بتزود السبستريت بتاعها، فممكن الاقي مثلا كرياتين في شركه بيقرا لحد، او يوريك اسيد مثلا بيقرا 15 وفي شركه ثانيه 25. فانا ممكن اخد الكاليبريتور بتاع الشركه الثانيه ال 25 واعمل بيه لينياريتي ستادي اللي ب 15، او اخد ال 25 واعمل لها سيريال دايليوشن، او ال 15 وابقى عارفه ان انا مش هزود عن ال 15.
شكرا دكتوره نيفين.